So good evening everyone, and thanks to the organizing team and Randeep sir for giving the opportunity. So basically I'll be discussing regarding the role of adjuvant therapies that is beyond TK and immunotherapy in advanced resectable RCCs. So as we know why there is a need for adjuvant therapy, because almost one-third of the patients present in curative stage, and among the patients who get resectable surgeries, again 30-40% patient had relapse, and overall the 5-year survival rate in these patients who develop metastatic disease is around 10%. So definitely there is a need to add some additional therapy in addition to curative therapies. And among these patients who undergo surgery, there are multiple risk scores to define who are the low risk group, who are the moderate risk group, and high risk group. And commonly we generally use UISS classification risk scoring based on the TNM and performance status and the grading score. And in this group we can see that the patients who are having a low risk, almost having a median OS of around 30 months, then intermediate risk having a median OS of around 18 months, then high risk group having a survival less than a year. So almost 9-10% in the low risk, 40% in the intermediate, and 60% patients in the high risk group have a relapse of the disease after this curative surgery, and their survival is in at least high risk, there not even a year. So this is a summary of adjuvant TKI in patients who underwent surgery, and out of this only the S-track was the positive trial. And in S-track you can see that the patients who had a T3 high grade tumor or T4 with or N1 disease has shown a significant benefit, along with patient having a grading tumor grade of 3 or 4. So, and in this the only benefit was seen in terms of the DFS. There was no any survival benefit. So based on this trial, so sunitinib is somewhat got recommendation in US countries, and it is a NCCN category 3 recommendation to patients who are having these high risk features to recommend sunitinib as an adjuvant drug for 2 years. So as we know, more and more data is coming for the immunotherapy in advanced renal cell cancer. So now these were tried in the adjuvant setting. So these are some key trials. Out of these, Keynote 564 was the positive trial, and we are going to discuss the remaining two, IMmotion010 and Checkmate 914 trial. So in short, the Keynote 564 included high risk patients which were T2 with grade 3 or 4 and T3, T4 and node positive disease, and limited metastatic disease who underwent complete resection. So these patients were included, and they have shown the initial primary endpoint of DFS. There was significant improvement, and the OS data is yet to mature, but in GUI score 22, the OS data presented for the metastatic group who underwent complete resection and sarcomatoid RCC, they have shown significant advantage in terms of OS benefit. So based on this Keynote 564, now this has got recommendation in adjuvant setting in these high risk patients. And now coming to the abstract which we need to discuss today. So first is IMmotion010, where it was a phase 3 study of atezolizumab against placebo in patients who underwent resection and high risk features. So they included a T2 tumor with grade 4, T3A, grade 3 and 4, then T3B or C or T4, or any node positive disease, or patients who had limited metastatic and underwent R0 resection, and included clear cell and sarcomatoid variant. So they randomized these patients atezolizumab for 1 year against placebo, and with key primary endpoint of DFS in intensive to treat from population, along with the overall survival in intensive to treat population and DFS and safety profile. So baseline characteristic was almost similar in both the groups, and you can see that there was some PD-L1 positive patients. Almost around 60% patients had a PD-L1 positivity. So the initial results was not favorable, and both DFS and OS was not significant in intention to treat population. And in the subgroup analysis, you can see that in patients who had some sarcomatoid variant or the PD-L1 which was higher side, that is more than 5%, they have shown some benefit. So based on this PD-L1 positivity in patients who has more than 5% of PD-L1 IC score or 2 or 3, they have shown some benefit. Otherwise, overall, this was a negative trial. There was no any benefit. So for this trial, the conclusion was adding atezolizumab will not be help in prolonging any outcome. And only in subgroup they have suggested, that is sarcomatoid variant or high PD-L1 expression, there may be some benefit. So again, the next trial was the Checkmate 914 trial. So it was a adjuvant nivolumab plus ipilimumab, and the major change is that duration of therapy was around 6 months in adjuvant setting. And again, almost they have included similar high-risk patients with the P2A, including grade 3, 4, then P4 and PT tumor and any node-positive tumor. And here they randomized patients for initial 4 cycles of Nivo-IP combination and followed by continuing Nivo for at least 6 months. And again, their key endpoint was the DFS, and the second endpoint was the OS and safety. Here again, you can see that almost the baseline characteristic in both the groups were similar, with almost 5% cases were having a sarcomatoid features. So again here, primary endpoint, that is DFS, was not met in either the independent review or investigator assessments. So again, this was a negative trial, but in this also they have shown patients who had a sarcomatoid variant or had a high-risk features like T4 tumor or node-positive tumor, they have some benefit. So again, this was the second trial which was in adjuvant setting, shown no benefit in terms of DFS, and there was some advantage in terms of in patients who had sarcomatoid features or very high-grade or T4 or any high-grade tumor. So from all these adjuvant trials, like in TKI era, the immunotherapy era also, except for pembrolizumab, the other 2 trials like atezolizumab and nivolumab combination with ipilimumab was not showing any benefit. So again, if we are planning any adjuvant therapy in adjuvant setting, any adjuvant treatment, so we need to choose our patients very carefully, and maybe I'll recommend only those patients who are having some limited metastasis and undergoing curative resection may consider, or patients who are having sarcomatoid features, we may offer immunotherapy. Otherwise, there is no any strong evidence right now at present era to recommend any adjuvant treatment, either TKI or immunotherapy. Thank you.